Hypochromic Microcytic Anemia. In hypochromic microcytic anemia, MCV, MCH and MCHC values are less than normal. So what is MCV? It is the mean corpuscular volume, that means the size of the RBC cells. Next is the MCH, which is mean corpuscular hemoglobin, that means the quantity of hemoglobin present in one particular RBC cell. And the next one is the MCHC, which is mean corpuscular hemoglobin concentration. That means the average quantity of hemoglobin present in one particular volume of RBC cell. So all of these values would be less than normal. So here you can see a normal blood smear, and in this the blood smear of patients suffering from hypochromic microcytic anemia. So what you see here, the RBC cells are small and they are less filled with hemoglobin. And this blood picture is seen in conditions like iron deficiency anemia and in conditions like thalassemia. The second type is normocytic normochromic anemia. So have a look at these slides. It gives you a fair degree of comparison between the normal number of RBCs and the reduction in normocytic normochromic anemia. So what you will see, the values like MCV, MCH and MCHC are all normal. Here the total number of RBCs are grossly reduced, as in blood loss anemia, hemolytic conditions, impairment in the production of RBC as in chronic renal diseases. And the third type is the macrocytic normochromic anemia. So have a look at the slide. On the left side you can see a normal blood picture with a normal RBC, and on the right side you are seeing macrocytes, and the MCV value here is above normal. And this is seen in conditions like vitamin B12 deficiency and folic acid deficiency. These conditions you will constantly see in your regular practice. So whenever you see that the MCV value is above normal, it should quickly click that it could either be a vitamin B12 deficiency or a folic acid deficiency. Next is the etiological classification. So it is the first one is the blood loss anemia, second aplastic anemia, third is the iron deficiency anemia, fourth one hemolytic anemia, and the fifth one is pernicious anemia. So first we will discuss iron deficiency anemia. It is the commonest type of anemia, and it is due to the deficiency of iron in the body. And it can be due to three reasons. The first reason is the increased demand of iron in conditions like pregnancy, lactation and growing children. There can be insufficient iron in the diet due to the extra physiological demand during these times. So the second reason is the dietary deficiency of iron. So that is due to the poor socio-economic status or ignorance of the source of iron in the diet. And the third reason is the increased blood loss. That is due to infestation with worms in the gastrointestinal tract. It could be hemorrhoids, epistaxis or GIT bleed. So RBCs here are microcytic with less hemoglobin. So it forms microcytic hypochromic anemia. So now we will see the iron metabolism. So as you can see in the first diagram, the dietary iron supply is 1 to 2 milligrams per day. Now iron is absorbed from the mucosal cells of duodenum. So the site of absorption is the mucosal cells of duodenum. The mechanism of absorption, you can see it in the second diagram. The food iron can be a heme iron or a non-heme iron. The heme iron is transported through the heme transporter of the brush border of mucosal cells. The iron from this non-heme iron is in the Fe3+ state, which is the ferric state, which has to be first converted to Fe2+, which is the ferrous state. And this is done by the duodenal cytochrome B of brush border. The ferrous is taken through a specified channel known as the DMT1. Now in the mucosal cells, these ions both from heme and non-heme, they are temporarily stored in mucosal ferritin. So the storage form is ferritin. Now depending on the metabolic rate, the iron is then taken into the bloodstream from the mucosal cells through specified channels known as ferroportin 1 channel. The ferrous is again converted to ferric state by hephaestin here. Then this iron is transported to transferrin. As you can see in this diagram, it is taken to various sites like liver, bone marrow, muscles, macrophage, and it is stored as ferritin. So as I said initially, the storage form is ferritin. The absorption from this duodenum, it depends on the level of circulating as well as the stored iron pool that you have. So, if the storage or the storage pool is normal, the excess iron stored in the mucosal ferritin, it is lost through feces by shedding of mucosal cells, and this procedure is known as the mucosal block theory.